Right, good afternoon, ladies and gentlemen. Welcome to Grand Rounds. My name's Tom Farley. I'll be chairing this, but only very briefly. I'm afraid I have to nip off as soon as I've said my last word to go and teleconference into a formulary meeting and then nip back again. And I may not return, so I'm looking hopefully that someone will take over if anything goes wrong. So anyway, thank you for coming. I have a few short parish notices before we kick off, and then we hear from Professor Tracey Wilkinson. I share an office with Will Anderson, one of the chess consultants, and he said to me, "What's going on in Grand Rounds? Is it some cadaver woman?" Which I think is probably vaguely accurate in some ways, I suppose, but she's more lively than the standard cadaver, and we'll hear from her in a bit. So, the School of Medicine is marking LGBT History Month with a photo competition inviting university students, staff, NHS colleagues and the general public to snap a picture of anything rainbow related and share it on Instagram or Twitter. Here's Will here. The cadaver lady is here, Will, you'll be pleased to hear. Anyway, share on Instagram or Twitter with the hashtag Dundee Rainbows, and the winner, judged by the school's LGBT Champions group, will receive a £20 Amazon voucher. More is available on the link on screen. It is LGBT month this month, and in 2 weeks' time, Graham Leslie from the sexual health team is going to give a LGBT-themed grand round. He's not told me what the topic is yet, but he says there's likely to be some sort of crude joke in there somewhere. The next is, if you're an undergraduate who has completed a BMSc, fourth year project, SSc or vacation studentship in diabetes or endocrinology in the past 18 months, you can be with a chance of winning £200 or £100 for the lucky runner-up. All you have to do is submit a 250-word abstract summarising your project's findings, and more information at the DCAT website. If you're a student and you've ever fancied working somewhere more rural than Dundee, then the integrated longitudinal clerkship is for you. A 10-month-long placement based in either Dumfries and Galloway or the Highlands. Please contact Penny Lockwood if you're interested. These are this month's staff development opportunities. If you're interested in learning something about teaching, training or presenting, this is so there's clinical skills, OSCE training and a learning cafe. The one with a star, you get free lunch. The other ones, bring your lunch with you. So, Professor Tracey Wilkinson, Professor of Anatomy down at CAHID. We met a few years ago whilst I was the SIP convener trying to plan what we would do with anatomy, and we built our curriculum for the first 3 years of medical school around anatomy because it has a very clear curriculum and plan, but we were very excited about this Thiel preservation technique because it does provide a really world-leading experience in dissection, prosection and surgical skills. My overriding memories of dissection rooms are it being very, very cold, and whenever I left I was desperate for a tuna sandwich, and I couldn't really work out why that was. I've not been back to the dissection room for a while. I'm sorry that I'll miss this, but I will be able to watch it because it's recorded, and remember you can always go back to the archive pages and watch them at a later date. Enough of my waffling on. I shall get rid of this and leave you with Tracey.
Just turn the lights down.
The lights. This one?
Yeah, that's perfect.
Is that right?
That's made a big difference.
There's a massive difference. Okay, right. Well, I'll leave you to it.
Thanks.
Okay, see you in a bit.
Is that better? Okay, right. So good afternoon, folks. I know Tom has very kindly introduced me, but I'd also like to point out that I have a medical student, or an ex-medical student. He's now an FY1 doctor with me, Dr. Fraser Peck, and he's going to talk about one of the projects he did with our Thiel bodies last year when he was a fifth-year medical student. So as Tom said, my name's, I know many of you in this room, but my name's Tracey Wilkinson, and I really came, we were quite keen, Fraser and I, to come along and talk to you about some of the translational kind of stuff we're doing with our Thiel bodies, and also perhaps to attract a bit of business. There are quite a few of us across the NHS and indeed from the University of Dundee, and we have a Thiel forum now where we work together to actually use these Thiel bodies to do some quite exciting things for the future. And that's what we're really talking about today. I'm going to start off with CAHID though, although it's very multidisciplinary and we've got a lot of people working on this stuff. What exactly sort of brought us to Thiel in the first place? And the Thiel, for those of you who don't know, is a particular type of embalming system which is very different to what you perhaps had when you were at medical school, where everybody used formalin. So obviously as a educational institution, we think that we should be giving our students the best possible experience as they come to the University of Dundee. We also think we have these lovely people who've actually signed up to donate their bodies, and we kind of feel if somebody comes in and we maybe dissect a hand or any part of that body and then they go away again, we failed them in some way. So these people who've actually signed that piece of paper, handed over their bodies to us to actually use in whichever way we can, we'd like to maximise the use of that body, and we've been doing that by using these in this translational medicine that we do here. The third reason, of course, is everybody's interested in patient care. Everybody's interested in both medics, surgeons, and all our other specialties getting better at what they do. And we therefore are trying to push the boundaries together with our clinical and indeed industrial partners to try and move medicine and surgery a bit faster ahead. Why did we in Carhead switch across to Thiel? We used to use formalin. Most of you, how many of you actually used formalin dissections when you were there? Excellent. Anyone been Thiel? Oh, very good. Excellent. We've got a few Thiel people here. Did you all dissect? Anyone not do full body dissection when they were at university, or almost full body dissection? Yeah, that's quite. Oh, okay. One. That's not too bad. Okay. So. Oh, did you not do any dissection at all? No. Okay. Fair enough. So Thiel, for those of you who haven't seen a Thiel body, they are very, very different. Here's some photographs. Obviously, the abdomen on the left, a bit of the chest area. You've got the arch of the aorta with its branches up at the top right there. And these bodies look very, very different to how you'd normally expect to see the formalin ones. They retain their colour, they retain their flexibility, they also are much more lifelike, and it allows us to do an awful lot with Thiel that we never could with formalin. Here's a little video, and you can see, for those of you who remember formalin, they were quite stiff bodies. I don't know if you remember trying to dissect the perineum, but it was quite difficult. Could you get those legs apart? Those sorts of things are quite hard. That's all gone by the wayside with Thiel, because these bodies are much, much more flexible. And this is one of our technicians at Carhead just demonstrating the flexibility, for example, of a Thiel hand or Thiel wrist. And it does mean, as Fraser will be talking about later, the functional anatomy side of things can be quite interesting. How do we use Thiel at the University of Dundee? We certainly use it. We've switched entirely across to Thiel now. We have no formalin bodies at all. All our teaching is done with Thiel, or indeed plastinates. We also plastinate, like Gunther von Hagen stuff. But largely it's used for our undergraduate teaching. So about half of our bodies, and at the moment we're taking between 80 and 90, probably up to about 100 next year, I would imagine. We're taking about 100 bodies a year, and half of those are used for our undergraduate teaching. We also do some research with some of our colleagues, both up here and down at the university. We also work with some industry for testing new and exciting surgical and medical devices, which we'll talk about, and we use it for skills training. So these are the sorts of areas we're in. This is probably your memories of medical school. You sat there with somebody telling you about the anatomy and perhaps doing a bit of dissection, learning bits and pieces. But we also do some quite interesting different things here. Because the Thiel is soft and because the skin is quite flexible, we actually teach, and in fact it's the first dissection session that our undergraduate first-year medical students do. They learn to suture, not fully, but they actually have a go at suturing on one of the very, very early sessions they do. They walk into the dissection room and they actually practice their suturing quite straight off, because you're able to do these with the Thiel bodies. We also allow them to intubate, so when they're doing the respiratory system, they actually intubate and they can actually see the little chest moving, which is quite exciting. And we're trying to increase these sorts of skills that we do. We're not trying to pretend we're the experts in skills, because obviously cutiary and clinical skills have that, but it just gives those students a little bit of a frisson. Well, not only are you learning your anatomy, but it's also very practical anatomy, and it can be used for other things. Hopefully at the end of all this we come out with little graduates who actually know what they're talking about, and for those of you who've been to Dundee, I'm sure you recognise this picture. We're also, of course, doing lots of research across the university. This is quite an old video, but it is one of my favourites because it's sort of slightly gruesome but also interesting. You can put tubes down anything in our Thiel cadavers, and this is something that was done with our colleagues in IMSAT quite a few years ago, Andreas Meltzer and Helen McLeod down there, and this is what our students actually do, our undergraduate medical students. We teach them to intubate, so they're learning the anatomy of the larynx and pharynx, and then they can actually allow this body to be inflated, and of course if the stomach starts gurgling they know they're in the wrong place. So it's sort of practical instant anatomy, if you like. We also, this is again from INSAT, an old video, and in fact this is an MRI, but again it's a live MRI, and we were allowing this body to breathe. I put breathe in inverted commas because it's not truly breathing, but what they were trying to do there was actually trying to ablate certain cancers in livers and organs, and using ultrasound and all sorts of other methods. And they were saying, well, if the organ is moving around, how can we do it? So we're using our Thiel bodies in that way to actually look at how can you try and target an organ when it's moving around as it would be in a live person. So all these people, although we're using cadavers, we're trying to make them as realistic as possible. Again, this is a rather nice urogram where someone's putting in radiopaque material, shows up the kidney tree, and we've shown this to quite a few people, and they go, goodness me, you cannot tell that that's not a live person. So there are lots of things that you can do with these bodies that you perhaps might not be able to do. As far as imaging goes, they image pretty well. There's one type of MRI that doesn't work so well, but you can MRI, CT, ultrasound, and this is our anaesthetic colleagues. Sorry, I've got Graham Houston there, but sorry, I beg your pardon, it is. It's our interventional radiology colleagues, I beg your pardon. And they were looking at some imaging, and also we can now make the vessel pulsate a little bit. We haven't quite got their heart to beat just yet. We haven't managed that with our cadavers, but we can do. IMSAT have been doing some very nice work where they're actually putting a pulsatile flow through part of the circulatory system so that these vessels are actually pulsating. Not quite in the same physiological way that a human would, but again, they're using these pulsated vessels to do all sorts of interesting things, which I'll talk about in a minute. This is just showing you the same, but giving you the coloured Doppler of actually this fluids passing through the vessel. This was a femoral vessel. It was some research that was done in IMSAT a couple of years ago. So there are quite a lot of areas that we're actually working in, trying to get the bodies more realistic, trying to use them in ways that might help our medical colleagues to actually push things forward. We work a lot with medical companies. This is Medtronic, and as you know, we have a strategic partnership agreement with Medtronic at the moment, and we're doing quite a lot of work with them in all sorts of different ways. And for those of you who aren't cardiologists or cardiovascular surgeons, this is an internal pacemaker which you actually embed into somebody's right ventricle. So that's what it looks like. I always think it looks like a little spider. The little feet are memory metal. So they get stretched out actually in the applicator, but once they're inside that right ventricle, those things come out and they clamp into the trabeculae carneae in the right ventricle. And you're thinking, well, why am I telling you this? There it is. What we're using the Thiel bodies for is to train the surgeons and interventional radiologists and all the other specialties that will be implanting these particular pacemakers in the right ventricle. And what we're actually doing with our Thiel cadavers, and this is where the pulsatile flow is quite useful, they pass the catheter into the femoral vein, pass it up backwards, thread it along through the right atrium, and then into the right ventricle. And the idea there is then they put the micro pacemaker into the right ventricle, it clamps on there, and again we're training our medical staff, and they're coming across from the States and all sorts of places to actually implant this medical pacemaker quite happily. And we tried it. We did quite a lot of experimental work with Graham Houston and his team at IMSAT, some of whom are here today. Did some quite nice research work to make sure that we could use the same ability in a cadaver rather than a real human. And now, of course, we're running courses where surgeons and interventional radiologists and different people can come across and actually practice this technique over and over again in our Thiel cadavers. There it is actually in situ. You can see the vertebrae. There's the actual delivery catheter, and there's the pacemaker sitting in its right ventricle, ready to ready to be clamped in. And of course, you can take it out again. They can actually practice taking them out and putting them in repeatedly. This is another device that Medtronic have been using. We talked about imaging, but with these Thiel cadavers, you can scope them anyway. You can do an endoscopy, bronchoscopy, arthroscopy. Basically, if there's a tube to thread something through, our Thiel cadavers allow that quite realistic experience of this. And this is a fairly new technology that Medtronic are developing. This is a CT scan of the actual patient. That's the bronchial tree which a computer program has put together from that actual patient. And then here's our bronchoscopist who's actually having a little go. And what he's trying to do, if you'll notice once I start playing it, there's a green... Sorry, let me just read that. Yeah. There's a green dot, which is a fake tumour, and the software has actually put this fake tumour right at the edges of the pleura. And what Calvin's trying to do here is he's trying to use the CT, the model of the bronchial tree, and his actual bronchoscope to find that tumour. So this one's quite a difficult one because it was right on the edge of the lung. But the idea is if you're treating a tumour, to actually treat it, you need to be able to find the thing. And they're using these rather interesting areas of software to try and improve the accuracy of and ability of the bronchoscopist to find these tumours and then to treat them with ablation therapy. And again, not easy to do on a real person, but we're working on using a cadaver to actually replicate the real situation. At the moment, we have quite an interesting project going on with Medtronic, and some of you in the room are involved in this, because the Cadavers and Medtronic, and we're all interested in medical education and where we're going in the future with this. What we're actually doing at the moment is we're using a system, Microsoft HoloLens augmented reality system, and we're working with Medtronic and a whole bunch of students from computing. It's four schools in the university: computing, medical art, forensic art, animation, dentistry, medicine, anatomy, forensic anthropology. We've got a whole group of students who are using Microsoft HoloLens technology provided by Medtronic to try and move medical education a little bit further, and saying how can you use these augmented reality glasses perhaps as a interventional radiologist, perhaps as an ENT surgeon, something like that. How can we use these augmented reality glasses to make that surgery, that medical intervention, much, much more interesting and much more useful for the actual doctor? And because they're young people and they like technology, and we've got a few computing people, we've just pointed them in a direction, said roughly, for example, I see Rod Mountains here, he's working with some of the ENT guys to look at temporal bone, point them in a direction, these students. Where can you go with this? And they're doing coming up with some really exciting ideas about improving medical training and how you use the HoloLens to improve the way people are actually being trained. So we've got some quite nice and interesting projects going on there. And eventually the idea might be that this training can be taken across to a cadaver, and we use the augmented reality glasses to help that training. A big part, and of course we work very closely with Cuschieri and the clinical skills training group, is with skills training. This is postgraduate training in the specialties. So for example, ENT, this is a chap who's actually doing some operation on I think it's pharyngeal oncology. I'm looking at Rodier, that's absolutely right. So there's a pharynx and larynx course, all sitting there with their laser glasses. This is not in fact a patient, it's one of our Thiel Cadavers lying there. And of course we are quite interested in working with our specialty colleagues to say, what things do you need to do and how can we as a university help you? So whether it's the pulsatile flow or putting in fake tumours or somewhere in some part of the body, we're quite keen to do it. The orthopaedic group can do arthroplasties. We have lots of arthroplasties, and here's a Thiel body with an arthroplasty. This is a few years old now, so it's a little bit out of date, but nevertheless they do quite a few arthroplasty courses. And Cuschieri are quite interesting because you're thinking, well, if you've got foreign bodies in the joint, for example, in the knee joint, they've been working on different materials that they can put into that knee joint as a sort of fake foreign body in there. And of course our trainee surgeons have to come along and fish that out or carry out an arthroplasty. So we're quite keen to work with people on making these bodies as realistic as possible. Anaesthetics is another area. We work very closely with Graham MacLeod, who's very interested in doing the research side of things. And I thought I'd show you some of his videos. Graham's got all sorts of really, really interesting ideas. And this was a project they did last year together with a psychologist using eye tracking software. And his hypothesis was, everybody knows if you do something for 10,000 times, you're going to be quite good at it. But his idea was, well, can you try and speed up the training of an anaesthetist by using eye tracking software, the Thiel cadaver, and actually trying out a block? So what Graham did is he said, okay, let's do I think it was a brachial plexus block they were doing. Let's have a look. Can we train people to be better at brachial plexus blocks? Here's his eye tracking. You see the little orange dot here? This little orange dot, that's where Graham, a senior consultant anaesthetist, is actually looking. And what he's trying to do is he's trying to put the needle in. So if you look at what Graham does, he actually stares at the screen, looks down, sticks the needle in, happy, looks at the thing, is my needle in the right place? Yep, I'm fine. That's Graham, senior consultant. Of course, as you can imagine, when you're not a senior consultant, you're trying to learn, your techniques aren't quite so good. So he was using the Thiel Cadaver and the eye tracking software to see how a younger person, less experienced, would do. And this is a more junior. Notice the blue dot, how it's whipping backwards and forwards, up and down. Oh my goodness me, I'm in the right place? Yeah, I'm look down. Oh no, wait, no, I'm not up again. So this is a person who's obviously learning the techniques of this, and we can demonstrate quite happily how long it takes them to put the needle in and where they're looking as they're doing it. And as you can see, the difference between Graham, our senior person, and the junior person is reasonably marked. And then what Graham did afterwards is he plotted out, sorry, that's coming to an end, he plotted out how long it takes for these people to do a brachial plexus block. So there's Graham. The time is quite short for a senior consultant a little bit longer, fellow a little bit longer. And then what they did is they brought in, I can't remember exactly the number, it was about 40 trainees, I think, and they brought them in, and over a 2-hour period, these people just did a repeated brachial plexus block. And the interesting thing about Thiel Cadavers is you'd expect they were actually injecting, not anaesthetic, but they were injecting fluid for each of these blocks. And you'd expect by the end of it you'd have this giant neck with a big fluid-filled neck. Not at all. All the fluid just disappeared, didn't see it at all, and it was an absolutely brilliant model to use because these people were doing 60 blocks over that 2-hour period. And notice the timing was reducing quite happily. By the time they got to the block number 41 to 60 in that 2-hour period, they'd brought their time down to put the needle in accurately much, much lower. And then interestingly, what they did is they waited 4 months, brought the same group back again, and even though they weren't quite at the level of expertise in terms of timing that they had been at the end of the period they'd come before, they were still quite a lot better than they had been when they first started. So again, this is just a way of accelerating people's training, and they were able to plot a graph actually, and I think this has now been published. There's our novices. This is how long it actually takes to put one in, but as you go through your training, by the time you've done 600 blocks as a senior consultant, your time is down to very little time at all. So it's quite an interesting piece of research saying, can we speed up the training and allow our doctors to actually get better skilled a lot faster? The other area we work in is in ophthalmology, and this is where I'm going to hand over to my colleague, Dr. Fraser Peck, because he wants to tell you about a lovely project he did while he was with us in Carhead for his final year, 5th year project last year. Do you want one of these? If you stand
Yeah, I'll stand there. Does these work? Oh, fantastic. So my name's Fraser, and I'm one of the FY1s in ophthalmology at the moment, as it happens. In my 5th year, we get an SSC project, which is a 4 weeks project. We can do whatever we like if we want to, or we can pick from a list. And this is what I chose to do. So this was the project when I presented it to the SOC, which is the Scottish Ophthalmology Conference, and I got an oral presentation out of it with Professor Wolfson and Professor McEwen. And what we're looking at is, can we teach how the eye moves better to students? So it's an area that we found to be quite difficult. So I've got a bit of a question. So this is for the audience. So it's not quite the MCQ, but it's pretty close. If you activate the trochlear nerve, and just from a neutral position, the activation causes the superior oblique to move the eye in what way? So if you think it's down and out, so the little triangle's the nose, put your left hand up. And if you think it's down and in, put your right hand up. See, this is quite interesting. So this was my problem when I was a 5th year medical student. I didn't understand this. And the reason I didn't understand this is because of the way it's taught. Sorry. Now, everybody's seen this diagram before, which is the clinical testing for ophthalmology. Well, most people will have done. So when you're doing your chest for the echo movements, you get something that looks like this. Is there a laser pointer on this?
Yes, there is.
Oh, fantastic. So superior oblique, oh, no, that didn't work. Superior oblique sits.
If not, just use the mouse.
Sits down here. And you see it immediately deviates and depressed. But if you actually go and look at a true anatomy textbook, which doesn't have a clinical aspect, this is what you see. And you see the superior rectus and the inferior rectus and the inferior oblique and the superior oblique all switched around, which confused the hell out of me. Right? And this is because this is what the anatomy does when you're just leaving it alone and you're not testing it clinically. But for us doctors, we're very interested in clinical anatomy, so we learn this, which leads to confusions. Because actually, if you actually ask someone what the superior oblique does and you say it immediately deviates and depresses, it's actually wrong because it laterally deviates and depresses, which took me 4 weeks to work out. And I had lots of very heated debates with various people, including consultant ophthalmologists who told me I didn't know what I was talking about, which went down well. So this is my study premise. What is the movements and how could we teach it? And to actually turn to Thiel for 4 weeks. And I produced something that looked a little bit like this. And this is my first model. And what we wanted to do was have one side of the eye to move and the other side of the eye to be a standard prosection. So we could quite literally take a student with a sample and say, what muscle is this? Where does it attach? What sort of movement would you expect that to achieve? And we had to do all sorts of stuff like trying to balance. And it got quite interesting quite quickly. Sounded like an easy project at the time, became quite difficult. And this is what we ended up producing. So this is my first model, which took me about 3 weeks to make. When you pull on a suture, the eye deviates. So that's a medial, lateral rectus. There's my inferior rectus there, and my superior rectus. Essentially what we allowed us to do was take the students and see if they understood the anatomy and then demonstrate the anatomy to them. And we got quite a lot of interesting responses from that, and they asked them, well, did this help? Did you find it useful? Did you find it interesting? A lot of students did, a lot of students didn't. So we took 42 of the students and we just asked them what they thought of it, and they gave us some feedback which we were able to use as a presentation. And we now have one of our models down here, so if anyone's particularly interested, I can show you it moving in real life. So the advantages I found to this was that the Thiel really can't be expressed how useful being able to move the muscle actually is, because you can display functional anatomy with the forceps and the biceps, and if you wanted to, you could cut the tendon and then show what would happen if you did try to pull it. And that's kind of my premise and where I took it forward, and I just took it a little bit further with this. But the great thing about it is you can tailor it to the learning needs of the student, which you can't really do in a formalin cadaver because the model doesn't move, so you can't actually show people various movements. Some of the students I was getting to do conjugate eye movements, so I could show them exactly why superior oblique was tested by medially deviating and depressing the eye, which you wouldn't stand a hope of doing if you were going to use it for something else. And of course students can interact with the model, which can be a problem when they break it, but don't worry about that. So it wasn't perfect. It was a 4-week project, and I think if I had a master's or a PhD to do it, I could make it a lot better, but with 4 weeks I managed to get it quite good. There's some technical issues with Thiel, which is predominantly the dehydration of the fat, which doesn't really bother most things, but in something like ophthalmology where you're dealing with very small movements, that's actually quite important towards the end. And you can unfortunately have your model destroyed if you don't fill out forms quickly, which is something else. So following the students' feedback, we're looking to add more models and more things to the area. So this is to a certain extent a call to arms to medical students and to the consultants. If there's something that you have that you find students don't understand, that there might be an anatomy way to fix it, spending the 4 weeks in the anatomy department in your 5th year is actually quite a good way to build understanding and build knowledge. And it's quite a good little project if you can get something going. And everybody I know who's gone and done a project has actually had quite useful things come out of it. So my final is, if you're a thinking person and you don't understand something, this is a good thing to do. But if you just want to be completely ruthless as far as applications go, this is so far what I've got just out of a 4-week project. So you get quite a lot of points from doing 4 weeks, which you wouldn't necessarily get if you spent 4 weeks doing a lecture or an essay on something, which is what a lot of my colleagues do. And I'll pass back to Tracey.
So, as I say, we're open for business. And if people are interested in finding out things, and we know obviously we're a research institution, this is a university, we do lots of exciting stuff, and Fraser's just one example of the sorts of people who just come along to us with some really, really interesting, nice ideas. And if we can help them out, we'll try to. And for those of you who are interested, as he says, Fraser's brought his second product along since the first one went by the wayside. So that's another little body. And if you want to come along and pull a few strings in a minute, you're welcome to do so. So really, we just wanted to come here and just give you a little bit of an overview of some of the work that's going on in the hospital across with our Thiel Forum and all our other colleagues here. We're quite keen to expand this, so if any of you are interested in using Thiel bodies for just about anything, we're always interested in having a chat with you. Of course, one of the main reasons we're here is to help our undergraduate students actually become decent doctors or indeed scientists or dentists. We'd like to support the donors who very generously donate their bodies, as I said right at the beginning, and probably more in this forum we want to push these boundaries of medical training and research and try and see where we can take medicine, and we've got a really, really nice high fidelity model with which we can able to do that. So if any of you are interested, you're welcome to contact me and see if there's anything you've got to say. Excellent, thank you very much. If there are any questions, Fraser and I'll be happy to answer them. Thank you. So, Fraser, do you want to join me? Are there any questions? Would anyone like to ask anything? We seem to have lost our chair, but... Yes, John.
I'll kick things off to get things going. So clearly, sexy is clearly the wrong term, but this is very advanced, interesting stuff. Can I just explore the issue of kind of cost and longevity and comparison with, for instance, animal models?
Yes.
Where some of this presumably you could pretty much embed something in a pig's heart and it wouldn't be that different, you practice most of the same things. Is this really clearly the way to go, or is it just a new technique that you're toying with at the moment?
Really good question. The cost, obviously an animal cost will be less than a Thiel cadaver, there's absolutely no doubt about it, but on the other hand we don't, our Inspector of Anatomy won't let us charge commercial rates. We're not about selling bodies here, we're about covering our costs for a start. So in terms of that, it's not excessively expensive. In terms of whether it's useful or not, if you want something that replicates the human as close as possible anatomically, and there are some areas that Thiels aren't good at, I hasten to say, if there's something you want to replicate anatomically really accurately, then Thiel is better than a pig. But if you're just trying to put needles in a type of tissue, then what's the point of using a Thiel? So it very much depends on what you're doing. And if any of you have been down to Cushieri, and I'm sure most of you have been through there at some stage, you'll see they start off with just virtual, for example, in laparoscopy, people just use the handles, do virtual stuff. Then they might move across to materials in a plastic box. Then they might move to a pig in a plastic box. And eventually, when you're getting a little bit more experience, you might say, okay, well, let's now look at the Thiel. So it's a high fidelity model, which does cost more than animals, but often you can't replicate whatever it is what you want to do in the animal. Something like the eye movements that Fraser was involved in, that would be quite, well, more difficult, I would imagine, with a pig. Or maybe it wouldn't be, I don't know. My pig anatomy is not great, so there's some things that you could do with other animals, but there are quite a few that you can't. And the fact that we've done all these lovely experiments with our colleagues in INSAT, where we can now have pulsatile flow, this kind of things, that's where the Thiel really does come into its own, I think. So it sort of depends on what you want to do, I'd say. Does that sort of answer your question, John?
Yeah, and the other one I suppose was, so like models like this, how long they might last. So that, typically you get preserved body in a formula pot that is totally uninteractive but lasts years and they're quite cheap. How long can things maybe?
So the answer is we don't actually know. So with my model, to our knowledge, we're the first people to use suture material on Thiel cadavers. What I do know is the suture materials that I put in a year ago still haven't dissolved. And they still move. So whether that means that it's at least a year's longevity is fine. To my knowledge, we can keep the model or keep the pro-section part of the model as long as we wish, providing it doesn't degrade, which I think sometimes.
Right. They're pretty indefinite is probably the best answer. By Scottish law, for those of you who might not be from this country, by Scottish law, all of our cadavers, we're only allowed to keep them for 3 years, which is different to the rest of the UK, who are allowed to keep them indefinitely. So once somebody's donated, once the body comes in, we have 3 years to do as much as we can with it before it has to go off to be cremated. We do cremate at Dundee. Having said that, a model like Fraser's, and most of these people will sign off, and we get them to sign off, are you prepared for us to retain parts? And if they allow us to retain parts, then we can take parts off as Fraser did, use that head in this case, or it might be a hand or something, and we can keep that indefinitely. The great thing about teal is they eventually do sort of dry out a little bit. Like everything, they're very wet. If anyone of you seen teal bodies are very wet compared to formalin. So over the 3 years they might dry out a bit, or the specimen might. But all you do is you just drop it back in a teal tank or in teal fluid for a bit, and it comes up fine. So actually, I would say indefinite is the answer you're looking for. They're very, very good in terms of antibacterial. Formalin, you quite often get fungal infections. I've worked with formalin all my life, and you can get fungal infections and other things coming up. We've only had one body since we've been turned to teal, which must be 6 years now, and we've had only one body that had a small problem, but otherwise we've been disease-free. Sorry, I say disease with inverted commas because I don't really mean that, but I mean there's no fungal growth or any other growth, so they actually are really, really well preserved. Yeah. Any other questions? Yes?
At the sort of cellular level, and the fact that they're so wet, what sort of effect does that have on the cellular and like the extracellular matrix?
Yeah, there are areas, histology isn't as good as some of the other areas. For example, if you take many cells, if you take nerve cells, for example, the membrane often dissipates completely. So you actually can't tell good histology. Skin doesn't do too well because as they're in their tanks, they stay in tanks for 3 to 6 months, for those of you who don't know the process. So that's why they're quite wet, because they're floating happily with their friends in a tank. The outer layer of skin sloughs off as well, so you don't get good skin. So a lot of the cellular stuff, there are some things you can do some histology on. Lungs aren't too bad, liver aren't too bad, but some of them, the membranes just disappear. So the histology isn't one of its strengths, I'd say. Yeah. But we have lots of colleagues in Glasgow who help us out on that one. Any other questions, folks? I don't really know what happens at the end of Grand Rounds because I don't usually come, but thank you very much for coming. Is there anything else that goes on at the end, or are we okay?
Tom normally does a little thank you, which I'd like to step in and do. Okay. So thank you very much to you yes. both for coming along. It's fascinating that you talk about the way the universities work more closely, the different schools, and I think this is a brilliant example. And just thank you very much for your time, and as ever, thank you to the audience for turning up.
Thank you very much. Thanks a lot. Thanks for coming, folks.
Everyone wants to take up the